Okay, so after that wonderful lecture and exposition by Dr. Cherian, who is a wonderful teacher, I believe is one of the best teachers in the country, who made intracranial procedures look so simple, but I can tell you they're not very simple. I'm going to go a little outside the brain in the brain circulation, and we are going to be treating and telling you about the 10 commandments of extracranial carotid artery stenting. And I have combined Dr. Dani's and my talk together. Now, let's see what we have learned. There have been two great trials. One is the CREST trial and the Sapphire trial. And what it has done is it is compared carotid artery stenting versus endarterectomy for carotid revascularization. And what we know here is the carotid artery endarterectomy is a wonderful procedure done by great surgeons, and in vascular surgery, it has very rewarding results. But carotid artery stenting also came in vogue, and then it has been tested over a large period of time and see whether it is inferior to carotid artery surgery or not. And as it has been seen that carotid artery stenting in selected patients and symptomatic patient is not inferior to carotid endarterectomy, and this has been seen by both these trials. If at all there is a little evidence or a little bias that the stents may be better, but it's not statistically significant. Having said that, now once we have two procedures, they are not competitive, but they are actually, comprehensive, and they actually have to be indicated properly in each of the patients, depending on the patient's need and the operator's expertise. The first indication is commandment is to choose the right indication. And the right indication for doing carotid artery stenting is that you should have a symptomatic patient with a simple high-grade stenosis. And these high-grade stenosis should actually be more than 50% in symptomatic patient by angiography, or more than 70% by duplex scanning. I'm going to be skipping this, and patients who have 99% or 100% internal carotid artery stenosis actually many a times will not require revascularization by carotid stenting. And in fact, in these patients, there could be more chances of doing more harm to the patient than actually helping the patient. Now, with this background, it's very important why is carotid artery stenting indicated, and why is it and how is it different from coronary artery stenting, because many of us are actually interventional cardiologists who have started doing vascular interventions. If you see the incidence of embolic strokes, most of these emboli would come from internal carotid artery lesions just beyond the bifurcation or at the level of the carotid bifurcation. 5% would come from the common carotid artery, and 3% would come from intracranial internal carotid artery. But many of these would also come from the aortic arch, and these aceratomas are a very important cause of emboli into the brain. So not that if you get a lesion in the carotid arteries like this, that you go ahead and stent these arteries. One should also look at other thromboembolic sites. The most important is the arch, aortic arch, which has an tremendous plaque burden, and sometimes it is also a left patient from the thromboembolic plaques can come in. So when you are assessing the anatomy, it's very important that you look at the aortic arch, you look at the takeoff of the common carotid artery, you look at the lesion, whether it's calcified, whether it has a strain sign which has very high embolic potential, if there is a clot there or an ulcer there, what is the condition of external carotid artery, especially if you are using a proximal protection device, and further lesions down in the internal carotid artery, the landing zone for your distal protection device, and the landing zone for the stents. So these are very important in doing carotid angiography. Most of this can be done, and it's better done by doing a CT angiogram, which is much better, gives you all this information non-invasively. Because, as I told you, if you are scraping your catheters to get an access into the carotid artery, you may actually cause stroke, peripheral strokes, by disturbing these atheromas. Now, after this, what is very important is you have to choose the hardware, and the hardware basically would start from the access. You should have a proper access, which is very important. I'm going to be talking about it. You should either have work on a 014 or 035 hardware or 018 hardware, whatever you are comfortable with. But it's very important that if you use small profile wires like 014 coronary wires, you may actually get much better results. Now, you can use either interest sheets or guiding catheters. The embolic protection device is a must in every carotid stenting. The course you had also sort of emphasized on this, and that's why the results of carotid artery stentings have become better. And we are always using self-expanding stents in internal carotid artery, except when we are doing a common carotid artery lesion. Closure devices are optional, and as Dr. Matthew said, we have to have a neurorescue team standby if the cardiologist is doing it or vascular surgeon is doing it. It's very important to have a neurorescue team on board, and if there is any problem, if they should take control and take care of the patient. Guiding catheters and sheets have advantages and disadvantages. The guiding catheters actually are advantages that they give you better control and they have better support. They have to be high profile 8 to 9 frames, and their transition is not very smooth. Well, the sheets can be used as 6-frame sheets, and they are very easy to use. Sometimes you can use Radial route for this. And the disadvantage is that they are less rigid, but the advantage is that they are lower profile. After this, you have to choose the correct access, and the access is determined by the aortic arch anatomy, the common carotid artery anatomy of the lesions, potential of external carotid artery, and anatomy of internal carotid artery distal to the lesion. So if you have a lesion like this, you have a type 3 arch and bovine arch, where it's very difficult to intubate this innominate artery or the left common carotid artery through femoral route. And the easy routes to go here would be a peripheral or a radial route. And it's very easy also to do sometimes direct transcarotid puncture. So if you have atheromas in this sort of aorta, it's very important that you don't go through the femoral artery or across the aortic arch. It's better you restrict to either radial or brachial route or a direct carotid puncture. And nowadays we have a fast cast system, which is the flow or the short transfer by carotid artery stenting, where you directly get access to the carotid artery, and then you reverse the flow. It's like a shunt from artery to the femoral vein, and this will prevent any distal embolization while we are doing it. Then we have the technique. The technique is very simple. You actually have a support and you intubate the common carotid artery. You pass the lesion with the 014 valve. Normally, we don't pre-dilate the lesion. You put in a distal protection device or a proximal protection device. Then you put in a stent. Sometimes you have to post-dilate. And after post-dilatation, it's good to flush the system and also aspirate the debris from there. And always do a final for vascular angiogram and an intracranial angiogram to actually see what is happening. Now, the distal and proximal protection systems actually, there is no actually head-to-head trial which says that one is better than the other, and there are umpteen number of distal protection systems which could be balloon-based or filter-based. All of them are good, but it's better to use the one which you are more familiar with. Then the other commandment is to choose the right stent. The right stent, actually, the stents could be self-expanding, could be tapered, and could be hybrid. The hybrid stents are a combination of a closed cell and an open cell design. Closed cell design in a lesion like this is better because this ulcerated plaque has a lot of embolic potential. And if you have more closed cells there, you actually would have less embolic potential of this atheroma. And you don't need a very rigid stent in the proximal and distal parts to prevent spasm as well as receptor stimulation. So that is why it is better to have open design there, and also the stent is tapered, it will match the size of common carotid and internal carotid. So these sort of stents are available by different companies, and I'll just skip this, but what is very important is now we have mesh-covered stents, and these mesh-covered stents actually have a very intuitive design. They would prevent any atheroma from protruding into the stent and into the lumen after a good procedure, and this will prevent the peri-procedural and late post-procedural embolization from the stented sites. Aspiration is very important. Many interventionalists do not do it, but there have been good studies that if you aspirate with the distal protection on, you may actually take care of all these atheromas which are hanging and protruding inside the stent at the time after you do a stenting procedure. And this correlates with a good post-operative result. Now, different types of aspiration devices are there. It doesn't matter what device you use. You can even aspirate from by using a tiny catheter. And if you do this, your peri-procedural stroke rate is going to come. But what is very important is one should respect the learning curve. One should not think that he is the best interventional guy doing his first procedure or the first 10 or 20 procedures. It has been seen in all the trials, right from Sapphire, Parker, and all this APVIC, Empire. All the trials have shown that the learning curve is the most important determinant to actually get better results, to improve the results from 6%, less than 6% to less than 3%. And this has also been shown in the outcome studies of Sapphire and the CREST trial. So in conclusion, what is very important is that carotid artery stenting is equivalent and non-inferior to carotid artery angiography in selected patients. We should have the right indication and the right patient to do it. And also we should respect operators and the operators' learning curve and also his experience. So you should have the right indication, right patient, right experience of the operator, and availability of a good neuroprofession team. If you have that, your results can match to that of carotid angiography in reasonably good centers which are doing good amount of carotid artery techniques. We should also understand that there is a variability in the results between the operators, between the centers, and also between the patients. So this is all we need to know about the 10 commandments of carotid artery stenting. And what is we are also going to show you a case where carotid artery stenting was used for carotid aneurysm. This is a patient who had a carotid aneurysm post many years after surgery, and the surgeons actually did a repair of this carotid artery. Later on, there was an aneurysm formation, and what you see here on the duplex is there was a very little lumen and a lot of thrombus burden within this aneurysm. And it was very difficult at that time to actually address this issue. The surgeon did not want to operate it because of various comorbid conditions. And the patient was referred to us. At that time, we did not have a proximal protection device. So we used a distal protection device very carefully. We saw that there was a thrombus which was trapped in the distal protection device. After that, we did an aspiration in a covered stent graft. This is a graft from the Bard company. This is, and after that, the patient had an excellent result. We did an aspiration and then took out the distal protection device. And this was the CT angiogram done after 1 year of the same patient, showing that stent is taken in the patient did very well. This is our personal experience in the last 14 years. This was reported from 1999 to 2014. We have published follow-up data of this 480 patients in 450 patients. We did bilateral stenting in different settings in 40 patients. We had a high technical success of 100%. 350 of these were males, 100 were females. The age of the patient, mean age was 65, they varied from 24 to 90 years. These young patients were patients of cardiacs who are tried with a non-vascular disease. And with this, 380 were asymptomatic, 70 were asymptomatic. Again, these asymptomatic patients had high stenosis and low flow, and these were patients of cardiacs with arthritis. We had 4 strokes, these were minor strokes in our series. And so in the end, the last component is what I told you, good judgment comes from experience, and experience comes from bad judgment. So it's not better to do a bad judgment and have a disaster and then learn. It's much better in conferences like this to learn from the disasters which other people have done and learn what not to do. And a careful thought and planning must go into every case. And in each case, the most important thought process to the individual outcomes and know and respect your limitations and other person's standpoint. So I will stop here and for brief question and answer. And after this, we will have a talk of from Dr. Roger Green, I think, who has joined. So over to you, Dr. Matthews.